Hello and welcome to the Women's Health theme. This is a presentation about miscarriage. Let's start by seeing what you already know. Question 1. When is a pregnancy loss considered a miscarriage up until? Is it 24 weeks, 23 weeks, 22 weeks or 21 weeks? This is in the UK. The answer is A, 24 weeks. After this point, it is no longer considered to be a miscarriage and rather is classified as a stillbirth. Question 2. What is the most common cause of miscarriage? Is it trauma, antiphospholipid syndrome, sporadic lethal chromosomal abnormalities, or increasing age? The answer is C, sporadic lethal chromosome abnormalities. These pregnancies were never viable, and some women might not have realised they were pregnant before they miscarry. Question 3. Increasing maternal age increases miscarriage risk. What percentage of pregnancies result in miscarriage above the age of 40? Is it 26%, 33%, 54% or 41%? To put it another way, if 100 women aged over 40 were pregnant, how many of them would miscarry the pregnancy? The answer is D, 41%. Increasing maternal age also increases the risk of chromosomal abnormalities in the fetus, such as trisomy 21, also known as Down syndrome. This presentation is going to cover what is meant by miscarriage, the symptoms and history, investigations and differential diagnoses, and clinical examinations and OSCE tips. To finish, we'll have a summary and some questions to see what you've learnt. So what is meant by miscarriage? A miscarriage can be defined as a pregnancy loss occurring before 24 weeks gestation or the expulsion of a fetus weighing 500 grams or less. As previously mentioned, any pregnancy loss after the point of 23 weeks and 6 days gestation is classified as a stillbirth rather than a miscarriage. So what types of miscarriage are there? The classification of a miscarriage depends on the state of the cervical os and the contents of the uterine cavity. A threatened miscarriage is a miscarriage that might happen. The woman will experience some vaginal bleeding, but the cervical os is closed, and ultrasound will reveal a viable intrauterine pregnancy. Remember that just like when a woman is in labour, if the cervical os is closed, the fetus is unable to leave the uterus. Inevitable miscarriage. A miscarriage is going to happen in this case. The woman will experience vaginal bleeding with or without pain, and the cervical os will be open, but the products of conception have not yet passed at this point. Incomplete miscarriage. A miscarriage is currently happening. Heavy and increased vaginal bleeding, pain and the passage of products of conception will be experienced, and the cervical os will be seen as open with products present within the canal of the cervix. Complete miscarriage. The products of conception have passed at this point. The woman was previously pregnant and now presents with a closed cervical os and empty uterine cavity. Missed or silent miscarriage. This pregnancy was never viable and is present within the uterus with a closed cervical os. The patient will experience the symptoms of pregnancy, but the pregnancy itself will not be able to continue. Early fetal demise. An empty sac will be seen within the uterus, but with no fetal tissue. In other words, a pregnancy with no embryo. A blighted ovum. This is a form of missed miscarriage, featuring arrest of embryonic development. A septic miscarriage is, as it sounds, a miscarriage and sepsis. Therefore, the presenting woman will have signs of infection, such as fever and abdominal tenderness. For a woman to be classed as having experienced recurrent miscarriages, she must have presented with 3 or more losses in a row. So what causes a miscarriage? As previously mentioned, the most common cause is chromosomal abnormalities of the fetus. Risk factors for this include increasing maternal age, and lots of these pregnancies will never be viable, although you can see pregnancies with chromosomal abnormalities that do continue, such as trisomy 21 or Down syndrome. Uterine structural abnormalities can also affect the chances of a miscarriage. For example, Asherman syndrome, uterine fibroids, or having a uterus that has a septum in it. Maternal health. Conditions such as blood disorders, autoimmune conditions, Gynecological problems and endocrine issues can affect the ability of the woman to carry the pregnancy. Active infections, including STIs, can also be a cause of miscarriage. Iatrogenic causes include amniocentesis and chorionic villus sampling, both of which are methods used in the Down syndrome screening process. The risk of miscarriage with these procedures is between 0.5 and 1%. Social factors of the mother can also affect the risk of miscarriage. So symptoms. Well, the symptoms will depend on the type of miscarriage, but can include vaginal bleeding with or without clots, amenorrhea, in other words, the lack of a period, and in some but not all, the woman can experience pain, both suprapubically and in the lower back, postcoital bleeding, or fever. It's important to bear in mind the differential diagnosis of ectopic pregnancy in any woman presenting with a positive pregnancy test and pain, and this should always be investigated promptly if suspected. The history of a miscarriage can vary and present in many different ways. For example, a 32-year-old woman has just been confirmed by ultrasound as being pregnant with twins at the gestational age of 10 weeks. On the way home, she notices bright red vaginal bleeding. She's in no pain and has no postural dizziness. During a 12-week scan, the midwife appears concerned and obtains a second opinion. The second sonographer confirms the absence of visible heart activity. Variations in presentation may include complaints of pain, both in the lower abdomen and the lower back, and some people may present not even knowing that they were pregnant at all. Investigations. A urine pregnancy test will confirm a pregnancy, and a full blood count can indicate the degree of blood loss and need to transfuse when managing the patient. Rhesus blood grouping of the mother is important when indicating the need for anti-D to be given to a woman. Anti-D is given to rhesus negative women to prevent them from forming their own antibodies against a rhesus positive fetus in the event of the exposure of maternal blood to that of the fetus, something which can happen during a traumatic event in pregnancy such as a miscarriage. This prevents the rejection of a rhesus-positive fetus in future pregnancies. Serum beta-HCG titers can give clarity in cases where there is more uncertainty, as a urinary pregnancy test only gives results of positive or negative in response to HCG. And a transvaginal ultrasound scan will differentiate between the stages and types of miscarriage by allowing the sonographer to view the contents of the uterus, as well as the state of the cervical os. Differential diagnoses that you should consider in a woman presenting with the symptoms that we have discussed. Ectopic pregnancy. This is a pregnancy that is located outside of the uterine cavity and is a gynecological emergency. A woman may present with suprapubic pain, unexplained pallor, tachycardia or syncope, and on examination the cervical os would be tender, as well as perhaps tenderness in the adnexe if the pregnancy was located to one side in particular. A hydatidiform mole, also known as a molar pregnancy, is the growth of an abnormal fertilized egg. You would find a uterus size larger than expected for the gestational age of the pregnancy. Cystitis is a differential diagnosis that should be considered, presenting with suprapubic pain and dysuria, fever and possible hematuria. And pregnancy coexisting with a bleeding polyp or large ectropion. This would explain a presentation of vaginal bleeding and would be determined by a speculum. In this situation, the pregnancy would not be affected. Now for some OSCE tips. When taking a history, don't forget to ask about the menstrual cycle, including the LMP, normal cycle length, days spent bleeding and clots, past obstetric history, including the gravidity and parity of the woman, and any previous miscarriage or ectopic pregnancies. Past gynecological history can help guide you towards alternative causes of symptoms or indicate whether the woman is at greater risk of a miscarriage. Your examination findings may be normal, but you should particularly look out for signs that would indicate an ectopic pregnancy or a septic miscarriage. So let's see what you've learnt. Question 1. When is a pregnancy loss considered a miscarriage up until? Is it 24 weeks, 23 weeks, 22 weeks, or 21 weeks? The answer is A, 24 weeks. Remember that after this point, it is considered a stillbirth. Next question. Increasing maternal age increases miscarriage risk. What percentage of pregnancies result in miscarriage above the age of 40? Is it 26%, 33%, 54%, or 41%? The answer is D, 41%. Remember that increasing maternal age also increases the risk of chromosomal abnormalities in the fetus. And the final question. What is the commonest cause of miscarriage? Is it trauma, antiphospholipid syndrome, sporadic lethal chromosomal abnormalities, or increasing age? The answer is C, sporadic lethal chromosomal abnormalities. These women may not know that they're pregnant before they miscarry. Thank you very much for watching.